Hello, my name is Derek Petty. I am a pediatric audiologist at the New York Eye and Ear Infirmary of Mount Sinai's Ear Institute, and I'm here with you today along with my colleagues to discuss the newborn hearing screening program and follow-up expectations. So to begin, why is it that newborns need hearing screenings? Well, about 1 to 3 in every 1,000 babies born in the United States have some degree of hearing loss. Although not as common as some of the other disorders in early childhood, untreated hearing loss can potentially have negative consequences on the development of speech and language, academic success, social and emotional development, and even the child's overall quality of life. Because children need to be able to hear in order to learn speech and language, newborn hearing screening and diagnosis helps ensure that all babies who have any amount of hearing loss are identified as soon as possible so that the introduction of early intervention services can occur as soon as possible as well. These early intervention services, which we will speak more about later in this presentation, aid in the development of normal communication skills. As I mentioned before, children with undiagnosed and untreated hearing loss are at risk for delays in language development, which can have a domino effect on the development of other skills that lead to academic success and their social emotional development. There are 2 newborn hearing screening methods that are commonly utilized by birth hospitals. Otoacoustic emissions testing, known as OAE testing, is performed by placing a sensitive microphone into each of the child's ears one at a time and measuring the echo response produced by a healthy inner ear. Because the microphone is very sensitive, this testing is best performed while the child is asleep. A present and normal response assumes that the test sound has made it at least to the inner ear. The testing is quick, taking only a few minutes per ear, which is why it is the preferred method in well baby nurseries across the country. The other method for newborn hearing screening is the automated auditory brainstem response test, also known as the ABR. It involves more preparation and time to perform relative to the otoacoustic emissions testing. The screening method measures how sound travels from the outer, middle, and inner ear portions up through the hearing nerve to the brainstem. A present and normal response assumes that the test sound has made it at least to the level of the brainstem for processing. Because children in neonatal intensive care units, or NICUs, are at a greater risk for hearing loss that occurs along the auditory pathway to the brainstem, this is the preferred method of screening for children who spend time after birth in these NICUs. However, some birth hospitals perform ABR screening on every child, regardless of their health status after birth. Both tests, the OAE and ABR screenings, present sound to each ear separately at one loudness level, and they look for a pass or a fail response. Fail responses are often called refer responses, as there is a need for follow-up when this result occurs. When a child passes the hearing screening with either screening method, there is an assumption that hearing is normal or near normal in the ear that passed at that particular moment in time. When a child refers on the newborn hearing screening, however, that does not automatically indicate that a child has a permanent hearing loss. There are a number of explanations for a failed newborn hearing screening, which include but are not limited to some of the examples presented here. Fluid, or vernix, which is the skin coating on a baby after they're born. Every time that's left over from the birthing process, it can lead to a refer on either OAE or ABR screening, as these cause a temporary hearing loss for a short period of time after the child is born. Once the fluid or vernix clears from the outer or middle ear, children with normal hearing will pass these screenings. This is the most common reason why some children refer on newborn hearing screenings initially, but eventually pass the screening once it's repeated. As previously mentioned, the microphones used to acquire newborn hearing screenings are very sensitive. Therefore, the testing must be conducted in a quiet space with a quiet child. Background noise from the environment or the child herself may result in a refer response on the testing. In addition, some preterm infants have undeveloped auditory pathways that result in refer responses on the ABR screening. For some of these children, as the system matures, their responses will improve. However, for some other children, the immaturity may persist throughout their lifetime. And finally, there is a proportion of children who refer on the newborn hearing screening who are diagnosed with hearing loss on follow-up diagnostic testing. This is, of course, the primary purpose of the newborn hearing screening, as these are the children who we will be following for rehabilitation. If a child refers on the newborn hearing screening after birth, the hearing screening is typically repeated immediately or just prior to discharge from the hospital. If the baby passes this immediate rescreen, no follow-up is typically necessary. However, it is important to know that a pass on the newborn hearing screening does not guarantee that a child will never develop hearing loss later in life. Regular well visits with the pediatrician are vital for confirming that developmental milestones are met with regard to speech and language development. Any delays with speech and language development may trigger the need for repeat hearing testing to ensure that hearing loss is not a contributing factor to those speech and language concerns. If a child fails the hearing rescreen in the hospital, then the baby will be referred for another rescreen. That next rescreen will occur after the newborn is discharged from the birth hospital. An appointment for this rescreen should be scheduled before discharge and is typically performed before the child is 1 month of age. However, recently, most facilities are unable to perform this rescreen within 1 month due to COVID-19 procedural changes. These appointments are being prioritized above all other diagnostic testing and will be among the first appointments to be scheduled once each facility reopens. If a child passes the outpatient rescreen, there is no more need for follow-up testing, but again, it is always recommended to monitor developmental milestones carefully to rule out the possibility of progressive or late onset hearing loss. If the result on the rescreen is still a refer in either ear, the child will be referred to a pediatric audiologist for a full diagnostic hearing test. While screening of hearing may be performed by technicians, complete diagnostic hearing testing must be performed by an audiologist with specialist training in pediatrics. Diagnostic ABR testing is similar to the automated ABR that may have been used for the initial hearing screening. However, this ABR is not a pass-fail screening test. It is a full diagnostic test that yields information about whether or not a hearing loss exists, and if so, how much and what type of hearing loss is present. Diagnostic testing can take anywhere from 1 to 3 hours, depending on how long the child sleeps. Once completed, the degree and type of hearing loss can be determined for each ear separately. However, sometimes it will be required for there to be multiple visits in order to complete all of the testing or to confirm the results of the testing at that time. So what is hearing loss exactly? Based on data from many children, a range of responses were established that were considered to be normal. Children with typical hearing are able to hear all of the sounds important for understanding speech within the normal range. However, children with hearing loss are unable to hear one or more of the sounds important for understanding speech within that normal range in either or both ears. With that said, hearing loss is not always all or nothing. Some children can hear some sounds within the normal range, but have difficulty hearing other types of sounds. Babies should respond to sounds in their environment by startling or opening their eyes wide in response to sounds. We don't expect babies to start turning toward sounds in their environment until around 6 to 7 months of age. Even if children respond to sounds in this way, however, it doesn't necessarily mean that they can hear all of the sounds around them or all of the sounds that are important for understanding speech. When hearing loss is diagnosed, it is described based on the amount, which is referred to as the degree of hearing loss. There is no minimum or maximum amount of hearing that one can have, so a percentage of hearing loss cannot be determined. Degrees of hearing loss are instead characterized by the impact that hearing loss has on someone's ability to communicate in a quiet environment, which ranges from slight hearing loss on the low end to profound hearing loss on the higher end, with various degrees in between. Slight hearing loss is thought to cause minimal negative impact on the ability to communicate in a quiet environment, while profound hearing loss would make it impossible to communicate without visual cues. Some of these terms may be misleading, however, because even a mild hearing loss can have significant negative effects on speech and language development, if left untreated for extended periods of time. It is possible for children to have any degree of hearing loss for one type of sound and a different degree of hearing loss for another type of sound. Speech sounds are made up of many different frequencies, which are the types of sounds, so any degree of hearing loss for any frequency can potentially have a negative impact on the development of normal speech and language. Two of the most common types of hearing loss are: one, conductive hearing loss, which is a hearing loss that's caused by abnormalities in the outer or middle parts of the ear, and two, sensory neural hearing loss, which have their cause in the inner ear or the connection from the ear to the brain. There are some types of conductive hearing losses that can be medically managed immediately, such as too much earwax. There are some types of conductive hearing loss that can be medically managed, but only when children are older, such as middle ear fluid or anatomically closed off ear canals. It is very rare, however, for sensory neural hearing losses in children to be managed through medication or surgery. So the most appropriate treatment is typically through the provision of hearing aids. Follow-up options for children with hearing loss will depend on the degree and the type of their hearing loss and will be guided by the pediatric audiologist. All children with hearing loss are going to be referred for a medical evaluation by an otolaryngologist, also known as an ear, nose, throat specialist, or ENT. Alternatively, some children may be referred to an otologist, who is an ENT with additional specialist training specifically in the ear. These specialists will recommend further medical testing to determine the etiology or the cause of the hearing loss, and whether or not the hearing loss can be managed through surgical intervention or with the use of medications. As previously mentioned, in cases where a child has hearing loss that cannot be medically managed immediately through surgery or medications, the best option is to provide access to soft sounds that the child is missing due to their hearing loss. This is done by amplifying these soft sounds enough for the child with hearing loss to be able to hear them through the use of hearing aids. So now we know that language development is driven by exposure to speech over time, and that children with hearing loss are at risk for language delays because of the reduced exposure to speech. It is not possible to predict children's language or educational performance on the basis of degree of hearing loss alone, and even children with mild degrees of hearing loss exhibit significant speech and language delays relative to their peers with typical hearing. Therefore, almost all children with any degree of hearing loss are fit with hearing aids as soon as possible after identifying the hearing loss to prevent these delays. The newborn hearing screening process has allowed children to be identified quickly, and therefore they are fit with amplification before the hearing loss can have a negative impact on development. This leads us to a discussion about the necessity of early intervention services. These are services that are implemented early on to prevent delays in development from occurring in populations at risk for these delays, such as in children with hearing loss. Research has indicated that children who are fit with hearing aids before 6 months of age have better speech and language outcomes than those who are enrolled in early intervention and fit with hearing aids after 6 months of age. Research has also shown that children with hearing loss who receive early intervention services and amplification have better language outcomes in some domains relative to peers with hearing loss who do not receive these early intervention services or hearing aids, and this is even true for children with mild degrees of hearing loss. Here to discuss more about the utility of early intervention in populations of children with hearing loss is Steve Pecoraro, the care coordinator for the Early Intervention Program at the Ear Institute of Mount Sinai.